All right, everyone. It is exactly 2 p.m. Eastern Time. We have a lot to cover, so without further ado, I'll go ahead and begin today's webinar. So good afternoon, everyone, and thank you all for joining us for today's webinar, Integrated Care for Kids Model Overview. This webinar is brought to you by OJJDP and the Center for Medicare and Medicaid Services. My name is William Moore, and I am with the National Training and Technical Assistance Center. As your technical host today, I would like to take a couple of minutes to discuss a few features of Adobe Connect webinar platform and provide a few announcements to keep in mind. Please note that this event is being recorded and will be published on InCK's YouTube page. The webinar recording will be archived on InCK's YouTube channel, where you can also view past webinars. For the event transcript and supporting materials, please contact the OJJDP NTTAC Help Desk. For those wishing to download a copy of the PowerPoint slides and other important documents, you may do so by locating the handouts pod directly above the chat area. Here, you will also find an FAQ for webinar participants that will likely address any technical related questions. Click on the file name and then click the download button. During today's conversation, presenters will address some of the questions posed during the meeting. Please type your question into the chat box as they arise. For those of you participating in today's webinar as a group, please take a minute to help us count. Go to the chat window and type in the total number of additional people in the room with you today. If you are viewing alone, there is no need to type anything at this time. And I'll give people just a couple of seconds to do that. Again, please type the number of additional people in the room with you today. If you're viewing by yourself, there's no need to type anything at this time. Following today's webinar, attendees will be sent a certificate of attendance. This certificate is sent approximately 1 hour following the conclusion of the event and is sent via an Adobe Connect thank you email. Please keep an eye on your email for your certificate. Please note that only participants that are registered and sign in will receive a certificate of attendance. At the conclusion of today's webinar, you will be provided with a link to a brief evaluation about today's presentation. The feedback you provide is used to assist in future planning and training. I will now turn over today's webinar to our moderator, Lynetta Jesse, for today's webinar. Thank you.
Thank you, William. Hi, everyone. I'm Lynetta Jesse with the Office of Juvenile Justice and Delinquency Prevention. Thank you so much for joining our call today. I believe you'll find this new model exciting and beneficial for the field of juvenile justice. So without further ado, I would like to introduce my colleagues from the Center of Medicare and Medicaid Innovation, who are our fearless presenters today. I'll start with our first presenter, Tawana Lucien. Ms. Lucien has focused much of her career on translating evidence-based research into practice and policy. Our next presenter, Melissa Robinson, has an extensive background and expertise in working with homeless populations in over 4 different states. These are just snippets of the awesome work these ladies are doing over at CMS. I will now turn this over so they can begin their presentation. Thank you.
Hello, this is Melissa Robinson, and thank you for joining us today. I am a project officer on the Integrated Care for Kids model at the Center for Medicare and Medicaid Innovation at CMS. I am joined by my colleague Tawana Lucien, who is a co-lead on the model. The model was announced in August of 2018, and we recently released our Notice of Funding Opportunity on February 8, 2019, which is currently available on www.grants.gov. Today's webinar is to provide you with an overview of the Integrated Care for Kids model, referred to as the InCK model, and to provide some insight into the Notice of Funding Opportunity, or NOFO for short. InCK is the first comprehensive pediatric model developed at the Innovation Center, and we are looking forward to offering states and local communities a resource to achieve the goal of improving the health outcomes of children. Today's webinar will cover an overview of the Center for Medicare and Medicaid Innovation, often referred to as CMMI, and how our center is able to develop models, the existing challenges and opportunities in child health, key recommendations from stakeholders who responded to our request for information back in February 2017 with regard to CMMI's interest in developing pediatric alternative payment models, focusing on methods to improve child health and interfacing with state Medicaid programs. We will also provide a high-level overview of the InCK model, its primary goals and interventions, as well as key model design features, and what the next steps are for potential applicants to prepare for the application process. All right, everyone, we have a lot of information to cover today, so please feel free to submit questions to the Q&A box during the presentation, and if time allows, we will do our best to answer some of the questions submitted at the end of the webinar. In case we aren't able to answer your question or you have any follow-up questions after today's presentation, please submit them to our help desk at healthychildrenandyouth@cms.hhs.gov. Now let's go over some background information. The Center for Medicare and Medicaid Innovation is a component within the Centers for Medicare and Medicaid and was established under Section 1115A of the Social Security Act to test models that improve care, lower costs, and better align payments to support patient-centered practices. The Innovation Center conducts an evaluation on each new payment and service delivery model we test. The statute specifies that measures in each evaluation must include an analysis of the quality of care furnished under the model as well as changes in spending. If the evaluation demonstrates evidence of improved quality or reduced spending, the Secretary of Health and Human Services may expand the duration and the scope of the model. Now I will review priorities in child health that drive the InCK model. Substance use often begins early in life. For example, a study of individuals aged 18 to 30 admitted for treatment of substance use disorder found that 3 out of 4 of those being treated began their substance use by the age of 17, with 1 in 10 starting by the age of 11 or earlier. There is also a concurrent opioid epidemic impacting the United States with risk factors that can be prevented early in life. This epidemic has been identified as a priority concern for the Department of Health and Human Services. Deaths from drug overdose are among adults of nearly all ages, and opioid overdoses accounted for more than 42,000 deaths in 2016. That's more than the previous year on record. In the same year, an average of roughly 1 in 25 adolescents 12 to 17 years of age misused opioids during the previous year. However, this rate doubled to 2 in 25 individuals by the age of 21. Lastly, substance use is often co-occurring with mental illness, and both share risk. Substance use prevention and coordinated treatment are crucial to reducing the number of deaths and related health care utilization among young Americans. And I just want to note that the information that I shared came from multiple sources, including the Substance Abuse and Mental Health Services Administration, the Center for Behavioral Health Statistics and Quality, the Centers for Disease Control and Prevention, and the National Center for Health Statistics. Okay, the current health system is not well equipped to identify risk factors for behavioral health conditions because often the earliest signs present outside of clinical care. For example, behavioral problems in school or a chaotic family situation known to child welfare. Some of these risk factors are adverse childhood experiences, or ACEs. ACEs are traumatic events that happen during childhood, like abuse, neglect, and family household challenges, including household substance use, and are cumulative over time. Exposure to risk factors during childhood is linked to the adoption of health risk behaviors and increases the likelihood of poor health outcomes later in life. We know that behavioral health conditions, including opiate use by children and youth as they grow older, drive significant morbidity, healthcare utilization, and premature death. 1 in 3 children covered by Medicaid are estimated to have emotional or behavioral health challenges, but less than 1/3 of these children are actually receiving the behavioral health care they need. Once diagnosed, their conditions are often more severe and treated in higher cost and less effective settings, like emergency and residential treatment settings instead of home and community-based settings. A number of federally funded programs play a role in addressing threats to children's health, including Medicaid and CHIP, Healthy Start, Head Start, Child Welfare, the Indian Health Service, and more. However, many vulnerable children are not able to access the optimal combination of these programs and services. For example, though 1 in 3 children in Medicaid are estimated to have behavioral health challenges, only 1/3 of those children actually receive care for their conditions. Pediatric beneficiaries often receive the wrong care at the wrong time because of late presentations of neglected illnesses and challenges, often including under or untreated behavioral and mental health issues. Late diagnoses are often treated in higher cost settings, like emergency departments and inpatient or residential settings. Despite a previous Medicaid demonstration that achieved results as good or better than inpatient settings at 1/3 of the cost. In addition to current data on child health that is driving the InCK model, we also received a lot of feedback from stakeholders in pediatric health services. Recognizing that there were opportunities to innovate in the space of children's health within Medicaid programs and that pediatric providers had not been afforded many opportunities to participate in healthcare systems move towards value at CMMI, the center released a public request for information in February 2017 about pediatric alternative payment models. To give a brief background on alternative payment models, they are developed to offer healthcare providers different payment structures that move away from paying a doctor regardless of outcome and towards payments for the provision of quality services. Diverse stakeholders across the delivery system responded to the RFI and identified various areas for partnership with CMS. Among those priorities included CMS working with federal partners to improve coordination between the medical, behavioral, and social support programs, including data sharing in order to put the child and family at the center of care, shifting care from more costly settings to home and community-based settings. Stakeholders asked that we align pediatric measures across Medicaid and integrate with other programs to strengthen quality measurement in general. The Innovation Center should work closely with each state Medicaid agency to invest in the infrastructure, including IT, to drive child health transformation. The full scope of the request for information is available on CMMI's website. The Integrated Care for Kids model is a child-centered local service delivery and state payment model aimed at reducing expenditures and improving the quality of care for children in Medicaid and CHIP through prevention. Integrated coordination of care and creation of sustainable state pediatric health infrastructure. This is especially targeted to those children with or at risk for developing significant health needs. And at this time, I will turn the presentation over to my colleague, Tawana, who will go over what has gone into the InCK model design and key features of the model.
Thank you, Melissa, and once again, thank you everyone for joining. So Melissa gave some broad strokes of the priorities in children's health that have driven the model development for InCK, and so we're going to try to map that for you onto those existing challenges into what the model interventions were designed to be and our model goals. So this chart that you see summarizes how the InCK model intends to address those challenges and priorities. From all the research and stakeholder identified issues, we've designed the InCK model to address the challenges related to the early exposure of behavioral health risk factors, fragmented health services leading to late diagnoses and treatments in high-cost settings, and limited infrastructure and payment misalignment. Through the interventions specified here, the model aims to achieve the outlined goals and improve child health services, outcomes, and payment strategies. So the three interventions that the model has developed include early identification of physical, behavioral, or other health-related needs and risk factors. In this, thinking through that intervention strategy, this is where model participants will be required to develop strategies to regularly assess the health needs of children in their target population, actively identify children with rising risks to determine which children have high levels of need, and then stratify those children by their level of need. And some of that stratification and how we think about that will be discussed further in the presentation. The second intervention is centered around integrating care coordination of physical, behavioral, and other health-related services, including shifting from inpatient and residential settings to home and community-based services for children with high needs. So, once the needs are identified and children are stratified, InCK model is looking for participants to provide early treatment or referral for children with these problems, with these health-related problems like substance abuse disorder and serious emotional disturbances. Integration of care across local service providers and case management will aid in keeping children out of hospitals, residential facilities, and other institutions, and ideally in their homes, which is more cost-effective. Care integration will support children with receiving home and community-based services and those other health-related treatments and supports. The third intervention built into the model is around funding and support for the development of state-specific alternative payment models, or APMs, which are geared towards aligning payments with quality measures and the infrastructure to support care coordination. So there's built-in flexibility in this model, really designed to empower states and local communities to develop alternative payment models that leverage the broad array of existing Medicaid and CHIP benefits, and it's essentially designed to be responsive to the needs of a state's populations and provider communities, and can be tailored to complement the existing health service infrastructure in a state or community. So the investment of CMMI's model funds will support this state and local innovation with their operations and infrastructure development and enable cross-sector coordination for patient-centered care and data sharing, and intended to help the model achieve the three goals that you see outlined on the column to your furthest right. And those three goals are improving performance on priority measures of child health, such as mental illness and substance use, This through early identification of needs and risk factors in children. Secondly, reducing the rates of out-of-home placement and avoidable inpatient stays through coordination of physical, behavioral, and other health-related services, and increasing the availability and use of home and community-based service. The third goal is to align payment and quality to drive child health transformation through funding and support for development of these state-specific alternative payment models and infrastructure. Ultimately, we're aiming to see program sustainability built into the development of this model. So now I'll transition into some of the high-level features of the InCK model to kind of dig down into what that chart now looks like in real life, we hope. So in order to implement the InCK model, we really recognize that there's a need for strong partnerships between multiple partners within a community. And for the purposes of InCK, we see that as being the state Medicaid agency, a local lead organization, and a partnership council. For this model, and if either the state Medicaid agency or this local lead organization will serve as the ultimate awardee for the model. So a little bit more information about what the responsibilities and expectations are of those partners. So the state Medicaid agency in InCK must really commit to partnering with the lead organization to develop and implement this model. The state is responsible for supporting local implementation by providing data on the population they plan to serve, supporting development of information sharing arrangements and infrastructure, and working to align support for the model across child-focused state agencies and designing and implementing this pediatric APM. For the lead organization, we see this as, the role for a local organization that meets the definition of a covered entity under HIPAA rules. The lead organization will serve a crucial leadership role of engaging and convening community partners via a partnership council and to integrate InCK's required core child services. This lead organization should also be a trusted organization that can understand and represent the needs of the community and be accountable for improving population-level care quality and outcomes and developing the required service integration protocols and processes. We really see this collaboration as important for purposes of identifying children at risk for significant behavioral health, substance use, and physical health needs among the intended service populations, and stratifying those who meet the thresholds of risk criteria defined by CMS into tiered care coordination and case management approaches. So this partnership is really an integral part of implementing the model. And then lastly, there is a partnership council. And so this partnership council is convened by the lead organization and will operate for the entire life of the 7-year model that the InCK award is intended to live on for. The Partnership Council will have the primary responsibility of devising strategies for its chosen community to achieve the coordination of service types that's required in our model. This council will consist of representatives from child service organizations with a vested interest in children's well-being and community-level service integration. It must include representatives from at least each of the core child services and any optional service types that the model elects to include. I will speak in a bit to the types of services that are required and may be considered relevant to those listening today. This council must also include representatives from local health department and community stakeholder representatives and Medicaid payers. And so if there are community groups that already exist in the designated area that meet this criteria, they can serve in this role, or one can be newly convened for the purposes of this model. So, who does InCK serve and what is our intended population for this model? The InCK model really intends to serve all Medicaid and, if specified in an application, CHIP beneficiaries, so Child Health Insurance Program. So serving all the beneficiaries from the prenatal period up to 21 years of age, residing within a state's administrative division that's identified by the model. So these areas can be designated by county or by zip code, metropolitan statistical areas, or some other state administrative division. We refer to this as the attributed population for the model. Attribution must be defined at the geographic level and will not be allowed in a statewide capacity or in a statewide manner and cannot cross state borders. This is mandatory for the purposes of holding our awardees accountable for population level targets in engagement, assessment, and outcomes, and is also relevant to the evaluation process for the model. A model can choose to focus on one or more contiguous or non-contiguous geographic areas and will also identify a potential area and population for evaluation purposes that is demographically similar to the attributed population. It is also important to note that the model does not allow programs to only address subgroups. For instance, participants cannot choose to only serve 18 to 21-year-olds or pre-adolescents or only youth with a specific health condition. However, the model does offer the flexibility to identify subpopulations of the broader attributed population that can benefit from targeted services as part of the larger population health approach that this model is seeking to implement. So I've made a lot of references to the core child services and the service types that we are interested in seeing integrated in this model. So I will talk through that here on this slide. So in designing a locally relevant model that incorporates the elements that I've reviewed, we are going to require the systematic integration of these. And so that includes clinical care, both behavioral and physical. To include, for physical care, that looks at including primary and specialty care providers. For behavioral care, that could include mental health, substance use and abuse treatment. This would include other services such as school, housing, for example, city housing authorities, food and nutrition services, that it could include nutrition and WIC programs, early care and education, which might include Head Start or home visiting programs, Title V agencies working in maternal and child health, child welfare agencies, and then mobile crisis response services, where there's a mobile response system that includes the ability to send staff to a child's residence to stabilize the crisis situation and perform a needs assessment. The mobile response system really should also include a central hotline that is widely advertised in the target population and can be called to trigger service initiation. In addition to the required services that I just mentioned, we welcome applications and models that really think about including other community partners that will help them achieve model goals. Lead organizations may consider working with the following types of entities that you will see on this slide, and that includes law enforcement, because we recognize that police are often first responders to address behavioral health crises and or child welfare issues. The inclusion of family and juvenile courts. We see that these systems and detention centers are well positioned to divert youth into community and home-based services rather than the juvenile justice system directly. So there's also the option to include civil legal aid, which has historically worked to address access to key health-related services, such as Medicaid and public benefits, including SNAP, and then other community partners. So awardees may think about including in their model other related child health service partners, and this could include a range of domestic violence centers, faith-based entities, therapeutic foster care providers. And so while some of your programs may sit within the required services I outlined in the previous slide, we think the ability to incorporate these optional services you see here might be a really good place for some of your programs and stakeholders to fit into the model. For many of the children, youth, and caregivers in InCK, or that are targeted by this model, they're dealing with behavioral health and substance use or juvenile justice issues. And the ability to incorporate the relevant agencies, partners, and providers into this continuum of care may be a great opportunity to reduce avoidable out-of-home placement through the use of increased access to home and community-based services, and to support the reintegration of youth who may have been institutionalized in a variety of settings linked to the risk factors that some of your programs might address. Taken together, the InCK model really can provide an opportunity to improve child health outcomes across multiple domains. To do so, applicants will tailor the InCK model to meet their local needs, so even this slide does not represent an exhaustive list of optional services. CMMI recognizes that the integration of required core services and the inclusion of recommended optional services will look slightly different in each model due to local context and variation in child health programs. The goal of the flexibility that we keep emphasizing that has been built into this model is to allow states and communities to design a care system that reflects the needs of the children in their attributed population. So in total, the framework for the InCK model really maps local services and a state-specific payment model onto a child-centered delivery process that supports the early identification, coordination, and integration of services for the most vulnerable children and youth with complex health needs who are eligible for or covered by Medicaid and CHIP. This slide provides a snapshot of our overall model framework. And as you see here, we reiterate, the Integrated Care for Kids model is the child-centered local service delivery and state payment model aimed at reducing expenditures and improving the quality of care for these children in a sustainable way. So, we have a little visual here. If you look to the right of the slide, you can see that the child and their caregivers are at the center of care delivery, surrounded by the partnering organizations that provide the services that have just been mentioned. The goal of the InCK modeled service delivery intervention is to provide children and their caregivers with one main point of contact that can assist them with their clinical needs and their other core child service needs. All of these community partners must be entryways in terms of determining a need using a standardized comprehensive needs assessment process designed by an awardee and their community partners. This process is one that can be initiated by the caregiver or a provider in one of the service delivery sites, and also by the caregiver through a crisis response system. You can see key partners at the top of the figure working together to implement this model, as in the state Medicaid agency and lead organizations that will partner to develop the infrastructure and processes necessary to support this care delivery change and an alternative way to pay for this. A total of up to 8 cooperative agreements will be awarded for this model for up to $16 million for the 7-year award period. So I've spoken through some of the elements. I'm going to move to talk about the population health approach and how we envision stratification and assessing children's needs. So this, our service integration model is based on, as I mentioned, moving children into service integration levels that consist of integrated care coordination and case management with increasing levels of intensity that's appropriate for the individual needs of a child and based on their needs assessment that is conducted for each child. So for the first level, which is really thinking through who is in the entire targeted population in a model service area, this is service integration level 1, where all children are considered attributed to the model in that area and or in the areas if an applicant has chosen multiple areas to focus on. And those children are assessed using a comprehensive needs assessment tool that is developed by a model, and that assessment is done at least every 12 months. If a child only requires standard preventive services, then they should remain in this service integration level 1. For children in level 2, this is where we start to see higher levels of needs, and children are beginning to show some difficulty functioning in places that they live, learn, and play. And so during the course of the comprehensive needs assessment, if a child is identified as having received more than one service in the last 12 months across multiple service areas that are targeted by InCK and exhibits a functional symptom or impairment, those children are then moved into service integration level 2 for integrated care coordination services. And in that service integration level, they receive this care coordination for at least a year and are also then reassessed every 12 months. For children who we consider as having some of the highest level of need, they not only meet level 2 criteria, but they are the children who are currently placed outside of the home or whom a provider has determined is at risk of being placed outside of the home. And this placement outside of the home is broadly defined and can include foster care, juvenile detention, or residential treatment facilities. These children will receive integrated case management for at least 6 months and reassessed every 6 months. This integrated case management is characterized by a multidisciplinary care planning team approach that includes the caregiver of a child and, when appropriate, the child themselves. Services here should really also support home and community reintegration. And no matter what service integration level a child is placed in, we really are seeking for services to be family and child driven and that are also ethnically, culturally, and linguistically appropriate. So we talked through some of that, and so what does stratification look like on the ground? In this image, which I hope you can see, we try to give a visual of what this process could look like. And this shows really a child entering any provider site and then being screened for their health needs as the first step. And then the outcomes of that screening process, moving a child along into different service integration levels based on their risk profile that's generated by that needs assessment. So we've said a lot of things, and so I want to recap some of the key pieces of the model, of the service integration approach. So while InCK's approach is really, as once again, I'm going to use the word flexibility, and designed to have a whole lot of flexibility in how service integration strategies are employed based on the local context, there are still some required elements to the model design. And so these 6 design characteristics include the population-wide approach, person and family-centered service delivery, streamlined and coordinated eligibility and enrollment processes, improving service access, integrating a mobile crisis response service, and then sharing information across providers as well as families and caregivers to the extent permitted by law. And so although there will not be a uniform strategy for each awardee, as I said, we recognize that the area's needs, geography, information sharing capacities will vary, and then will make the design of every model for every award look a little different. So one of the other pieces that we've talked about in terms of pushing for sustainability is to think about different ways to pay for services. And so the alternative payment model piece of this is really focused around the payment approaches that are intended to add some incentives to deliver higher quality and cost-efficient care. And so states will work with CMS and their lead organization to design and implement one or more child-focused alternative payment model approaches. And so this model will require that participating states develop APMs to support, at the minimum, care coordination, case management, and mobile crisis response and stabilization services using authorities available under Medicaid and CHIP if an applicant chooses to include CHIP beneficiaries. States with existing APMs can modify them if necessary to meet the model's criteria. Those APMs that are designed under the InCK model will assist in providing accountability for achieving the model goals, related to promoting accountability for improved outcomes such as rates of avoidable out-of-home placement and opioid use, and also ensuring the sustainability long-term for the model. So this model is intended to be a 7-year model, an award that will be implemented using a 2-phase implementation strategy. There's 2 years of pre-implementation in which we work with states to develop their infrastructure, implementation, and evaluation plan, and a 5-year model performance period in which states and lead organizations and their council will really implement the model and report required data to CMMI. And you'll see in that figure that for the first 2 years, there are up to $6 million available per award, and then for the 5-year performance period, there are up to $10 million. And for the life of the model, we intend to provide technical assistance and peer-to-peer learning and support, as well as robust evaluation activities. So I'm going to turn this back over to Melissa to relay some of the next steps.
All right, so preparing a strong application for this model will require time and coordination. Now that we've announced the NOFO, and we hope you've obtained useful information through this webinar, this is your opportunity to begin working together within your local community and your state to determine how you can be a part of this model. As we noted, we expect the model to be organized by a HIPAA-covered entity in step with the state Medicaid agency. CMS expects that the key model participants will make their own determination as to which entity will serve as the awardee organization. The InCK model will not participate in that decision-making. It is our hope that you will convene with your state and communities to determine who are the likely partners that can make this model work, and begin establishing if you and how your juvenile justice programs may be able to contribute to applications coming out of your state. Key dates to note. All applications are due by 3 p.m. Eastern Standard Time on June 10th, 2019 via grants.gov. And we anticipate announcing awardees in December of 2019. For those of you who think this may be a good opportunity for the children and youth in your state or local communities, we encourage you to seek out details about submitting an application on grants.gov. It is strongly encouraged that you begin the process of submitting an application in advance of the deadline. There are a number of items required as part of the application process. And if you experience difficulties in any way during the submission process, you may find yourself unable to submit on time and inadvertently have your proposals deemed ineligible for consideration. Once again, we anticipate making up to 8 awards for up to $16 million per awardee. This model will use a 2-part funding strategy over the 7-year period, with awards anticipated in December 2019 and model start in January 2020. Again, we hope that you have found this overview helpful. We recently conducted a full webinar on the NOFO application, which will be available on our website in the coming weeks, but we also plan to host additional webinars intended to be useful for potential applicants in developing their proposals. These include an 8 p.m. webinar in early March, where we will provide a more in-depth review of the APM guidelines and requirements for the NOFO application, a webinar on February 28th on adverse childhood experiences conducted by ASLO and CDC that delves into the impact of ACEs on child health and behavioral health outcomes and linked to the InCK model. along with a second NOFA webinar in March. Please feel free to send questions to our help desk by emailing healthychildrenandyouth@cms.hhs.gov. If you would like to remain abreast of ongoing announcements or the release of any FAQs, please visit the InCK Model website at innovation.cms.gov/initiative/integrated-care integrated for kids-model, where you also can subscribe to our listserv. This information is also featured on this slide.
So at this time, we've completed our overview. We really wanted to kind of give you all and this audience an opportunity to hear a bit about the model. And we recognize that for some folks, some of this information is completely new, and we're just really excited to have an opportunity to speak with you all. And so we've received a few questions, and we have a bit of time. So we may just take a few minutes and answer some of those, if that's okay with our event, with our specialist, with our host.
That is fine. I would really like to get as much information to the field as we can, so please move forward.
Okay, thank you. So we have a question about what age range are we talking about for this model, and I know we use the word pediatric a lot, but for the model we really are expecting and requiring the screening, assessment, and integrating care and coordinating care for young people from the prenatal stage of birth to age 21. And so that we are covering the gamut of what is determined as child under Medicaid beneficiaries. And so to another question about juvenile services, and so for the purposes of this model, while it is not necessarily a core child service, we do see it as one of the recommended optional partners, and we recognize that some of your programs cover a broad range of items. And so, some of you may sit within larger core child services, but we do think that there's an opportunity for this community of stakeholders to be connected to the model through the optional services. For those organizations and entities that are already participating in other demonstration projects or other CMMI initiatives, none of it precludes you necessarily from applying to this model or from participating in this model. There are, if an existing program that is already like an awardee of one of our CMMI models is interested, there is in our Notice of Funding Opportunity application a process where program duplication has to be addressed to make sure that there's no supplanting of funds and things of that nature. But we have not precluded, just out of the gate participants in other demonstrations from being involved in this one. And so can a program target only a specific age range? Once again, that is no. You can't just choose to only screen like adolescents or teens. What you can do is think about how do you screen the entire age range, and then maybe wrap think about the risk needs for those populations that may elevate them into tiers 2 and 3. And think about the services that may be needed. But it is important for the population health approach and to drive changes in outcomes that models pay attention to screening, and especially for the entire age range of the population in the designated communities that an application chooses to target. That looks to be about all of the questions. If there are any other questions, I'll wait a moment to allow anything else to come in to the chat. And while we're doing that, I would definitely encourage, I know in the handout section, our hosts have provided our notice of funding opportunities, so you can pull that right down from your handout pod. If you want to skim the notice of funding opportunity, download it, save it, share it with colleagues, and really kind of mark all over it and try to identify questions that you may have after this presentation. We don't have any restrictions on universities serving as lead organizations, in the sense of we have a lot of university hospitals and so forth that may choose to work within this sphere. A big component is being an eligible HIPAA covered entity that is also subject to the privacy rule and can manage a lot of the convening of partners that will be required of this model. So that's something that is important to think about when identifying who might be a lead in the community versus a partner on the council or a partner in thinking through developing the approach and strategy for integrating and coordinating care. So I just want to be clear, if folks are participating in other CMMI or Medicaid models, you can still be eligible to submit an application. The eligibility, those guidelines are very well detailed in the notice of funding opportunity, but participating or being a current awardee does not preclude you from participating, from submitting, or anything of the sort. So I hope that answers. So there are requirements for being able to provide us Medicaid information on the population, around who is a Medicaid beneficiary in a population for the life of the model, and annually and quarterly. So it's important that an organization that is a lead also be able to share in that infrastructure process and sharing of data around Medicaid. So I think that is an important aspect of this. This funding is specific to the 50 states and is a Medicaid, is intended to serve Medicaid and CHIP if chosen beneficiaries. So I think we've gotten all of the questions. This webinar, and I believe that OJJDP will be making this available through their regular channel at a later time. I will allow our host to talk about what that timeline is, but please feel free to share the funding opportunity. Please feel free to go on our website and subscribe to the listserv. If you feel like a question wasn't really answered, or if you have additional questions that come up after today, we really encourage you to reach out to us through our mailbox and through our inbox, as you see on the screen, Healthy Children and Youth at cms.hhs.gov. We don't have a limit on the number of questions that we will answer. We are taking inquiries throughout the life of our application period and even thereafter. And so please feel free to continue to reach out to us. We hope that the stakeholders here may see this as a useful opportunity or to share with others that you may consider it to be useful for. So I will Melissa and I thank you from CMMI's perspective of joining us and for OJJDP allowing us to present this information today. I'm going to now turn this back over to our host and go from there. But thank you all once again.
Thank you so much, Tawana. And I think, oh, I'm sorry, William?
No, please, Lynette, after you.
Okay. I just want to say thank you for all the hard work you all are doing over at CMS. We appreciate you coming to us and delivering this presentation. I think it's needed in the field, and I thank everyone who participated on this call. Please make sure you look at, I believe the webinar is going to be posted at InTAC's YouTube within a week of this webinar, of this date. So you will be able to have access to it later. Again, thank you from OJJDP. We appreciate your participation.
Great. Thank you again, Lynetta, and thank you to our presenters with CMS for a very lively and informative discussion. Just before we wrap up, I have a few reminders for everyone. Please know that you may contact InTAC through the website displayed on this slide. You may stay up to date on the latest information by signing up for InTAC's TTA listserv. Also, don't forget to check us out on Facebook at OJJDP TTA. You can also contact OJJDP via the Help Desk by following the following contact information on this slide. And just a reminder, these slides and other handouts are available in the handout pod located directly above the chat pod. As a reminder, the webinar recording will be archived on InTAC's YouTube channel, where you can also view past webinars. And for the event transcript or other supporting materials, please contact the OJJDP TTA Help Desk. Please take a moment to review this disclaimer. And lastly, we would appreciate it if you could please take 5 minutes to complete the feedback evaluation. Thank you again for joining us today. Have a great afternoon.
The host has left the meeting, so at this time, the meeting will come to an end. Thank you and goodbye.